Also very happy to welcome our state president in the event that he has been selected as the national vice president for next year. So now we are going to hear the presidential address from our state president, Dr. C. N. Raja. Dr. C. N. Raja.
Thank you, Dr. Anbrajan. Good afternoon to everyone. Director of Studies, Dr. Govindarajan, Secretary, IMA, CGP, Dr. Anbrajan, our Secretary, State Secretary, Dr. Ravi Kumar, Dr. Ramakrishnan, President-elect 2020, Dr. Palanisamy, President-elect 2021, and the most important personalities of this afternoon, Dr. Palanisamy, retired DPH, Dr. Naminathan, consultant pediatrician, Dr. Raghunandan, professor of medicine from Madras Medical College, and other office bearers, Dr. Tyagarajan, Dr. Susidhar, Dr. Selva Kumaran, and other participants. In fact, this is an introductory or warming up ceremony for the hospital infection control fellowship course. The idea of starting such a course was conceived by none other than Dr. Swami. When I was talking to him in an informal talk during this pandemic period, we thought there are many private hospitals, especially small and medium hospitals, are lacking in having a clear-cut protocols in controlling the infections, and also they are not following any set norms and rules and regulations. Those who are in NABH accredited hospitals, they know how much importance is been given to in this infection control, and there is a set of people to have monitoring and controlling and keeping the data on the infection control. As the director of studies said, the infection, we thought we are getting over the infectious diseases and we are concentrating only the NCD. But no, this pandemic has really shown us that we have to be very careful in dealing with infection to reduce the hospital infection, cross infection, ICU infection. Also, the getting resistance, antibiotic resistance, which is a big menace. Nosocomial infections also biggest problem. All those things we need to address by taking simple and regular protocols and habits, make them a habit, simple hand washing, even training the paramedical personnel and others, ambulance driver, watchman, reducing the crowd and the attenders, the problems with the theater, all those things we need to address. It's a big subject, and I'm extremely happy the top people, Professor Raghunandan, who is known to us for a very, very long time, to most of the IMA members, very friendly, simple person, and also we've been constantly interacting with him and Dr. Swami all these times along with the government. Whenever we go to the government, we will be sitting along with these people and discuss in-person meeting, in Zoom meeting, along with the health secretary, health minister, sometimes the chief minister also. This is the way we exchange our ideas, views, and implementing the effective measures in order to control the infections, especially in dealing with the COVID-19. So Tamil Nadu is doing extremely well in this subject, and it was appreciated by none other than our Honorable Prime Minister how we are dealing this. This is because of these key people telling us how to go about this. And Dr. Naminathan is a very, very popular name, not only in Coimbatore, all over the state and the country. Though he's a pediatrician, he's very, very, very keen in all the academic activities. I've been constantly talking to him and in touch with him on so many times on so many occasions. And with this few words, I am happy that, and I really appreciate Dr. Anbarajan when we said that we are going to want to start such a course. Immediately got out of the idea and contacted Dr. Swami, Dr. Neminathan, Professor Raghunandan, and made it possible. That shows his involvement and the enthusiasm. This is just warming up, and we have other protocols. Since we have to pass it in the state council, as our secretary already mentioned it to me, we will do that within 15 days time, and we'll formally launch the course. And I hope lot of people will be interested in such course because we need to handle it in an effective way, including the biomedical waste, all those things. So this is a very big subject. Without wasting much of time, I'm very happy to be here to inaugurate the CME on the hospital infection control. So kindly pardon me, I'll be hearing the audio, but I'll be not be switch on my video because I'm just driving now, but I'll be hearing all the conversations. With this, I am once again, I congratulate all the faculty members and the IMCG for the wonderful afternoon. Thank you, sir.
Thank you, our President, sir, for
Anbarajan.
Sir. Sir, thank you, sir. Thank you, Dr. C.N. Raja, sir.
So I'll be signing off on the video, but I'll be hearing the audio.
Okay, sir. Right, sir. Thank you, sir. Thank you, our President, sir, for your very enthusiastic presidential address, as well as kind enough to inaugurate the FCID 2020 new program, new course in IMA CGP GNSP. Now I request our vibrant honorary state secretary, Dr. A.K. Ravikumar, to say the special address. Dr. A.K. Ravikumar, sir.
Thank you so much, sir. Thank you, Dr. Anbarajan. Respected President, congratulations, sir, for you for having been elected as the National Vice President for 21-22, sir. It is a big feather on the cap of IMA Tamil Nadu. And the entire country has got very big, from the Tamil Nadu IMA, the expectations from IMA Tamil Nadu. And for the first time in the country, I think we have two major posts for IMA Tamil Nadu. Dr. J.A. Jailal, the vibrant, voracious person from our branch, has become the national president for 2021. And it's a very big, proud moment. And our Dr. Anbarasu has become the CGP National Secretary, and also Dr. Rekha has become the Joint Secretary. Congratulations to all. And respected office bearers of the CGP, you are doing wonderful well. And I'm very happy that Dr. Anbarajan is very, very active. I know him for the last 15, 20 years. Whenever we give some work to him, he does it with sincerity and total involvement. And all the programs which he has conducted so far, and the new course which he is going to come up, which is getting inaugurated by our President today. And as our President said, after getting passed in the State Council, forthcoming State Council on November 1st, we will be starting the program of this infectious control. And respected Dr. Kulandasamy sir, you are an asset for us, not only for our fraternity. Your involvement, your simplicity, your knowledge, everything is exemplary, sir. And your postings and your videos and the things which you give for the public awareness, and the information you give to our profession, not only for our doctors, your information to the paramedical people, everything speaks about your excellency and your involvement and your commitment. And even after retirement, many people after retirement, they really retire. But Dr. Kulundeswamy sir, he has not retired. Actually, he has started a new generation now. And hats off to you, sir. And thanks for accepting our invitation. When I was chatting with Dr. Kulundeswamy sir, I invited him to take part in IMA activities. He readily agreed, and he has taken up this commitment of conducting the infectious control program. Thank you very much, sir, for being with us. And Dr. Raghunandan, you all know, he is an eminent professor, and entire Tamil Nadu state machinery, health machinery, will agree that his efforts in the COVID control is exemplary, and the many patients who get admitted in the government hospitals and the protocols of treatment protocols framed by Dr. Raghunandan and his team has helped in saving many lives. Hats off you, sir, and thanks for joining with us for this program. Neminathan, he is my classmate. I know him for many years, and he is a very enthusiastic and well-informed person, and he is very knowledgeable also. And once any thing is given to him, work is given to him, he will not sleep without completing the assignment. So thanks, Neminathan, for coordinating this and for taking up the infectious control program, and hope you will get more people enrolled in this program, and we will do the best and we will spread the knowledge to all. And can I have the slide sharing, sir, regarding the credit hours? I just wanted to give some information to our members.
You can, sir.
Yes, sir.
Yes.
So see, regarding the credit hours, Tamil Nadu Medical Council is giving the credit hours for all the programs, but there are certain norms based on which they will be giving the credit hours. And the most important one is we are supposed to submit regarding the program well in advance to the Tamil Nadu Medical Council, so that they will go through and they will assign a person to see whether the program is going on properly, and we will be getting the information maybe before we start the program, or sometimes even later after completion of the program. So anyway, whoever takes parts in the program, please see whether the CME is approved and get the CME credit hours. And once you attend the CME, see to it that you are logging into the correct CME program. And as our Secretary of CGP has told, you have to enter your name, Tamil Nadu Medical Council registration number, the branch which you are belonging, your email ID which you have registered with the Tamil Nadu Medical Council, and the mobile number which you have registered with the Tamil Nadu Medical Council in the chat box. This is only for attendance. Just registering your name doesn't mean that you will get the credit hours. So through email to IMA Tamil Nadu, email imatamilnadu@gmail.com, within 7 days of the completion of this any program, you have to send the details, like again the name, Tamil Nadu Medical Council registration number, the branch to which you belong, the phone number and email ID which you have registered, and the topic which you have attended, and the date on which the topic was conducted, CME was conducted, and you have to pay for the CME. So I'll give you the details of the payment portal so that you can pay the credit payment. And this payment, basically it is 50 rupees. And if the program is longer duration, we will announce in the program about how much you are supposed to pay. So for this program, you have to pay 50 rupees. And while you send the email, please note it. You have to provide all the above details along with the transaction ID, because without the transaction ID, we may not know who has sent the money to our account. So unless that is also being sent, you will not get the credit hours. So kindly pay the credit score charges as and when announced by us, depending upon the duration of the CME program. For this program, it is 50 rupees. The name to the account to which you have to send is the IMA Action Fund, Bank of Baroda. Account number is given here. IFSC code, you take, you see that it is BARB and it is not O, it is 0. Many a times I used to get the phone number, phone calls that it is not getting credited, it gets bounced up. This is 0, actually 0, BJPAMB, Tambram branch. So thank you very much. I wish this program a great success, and over to Dr. Angurajan.
Thank you, our Secretary Sir. Not only you have given special address along with the very much needed information for all the members who have been attending today regarding getting their credit hours. We will be in future, will be very much alert that the programs are being arranged and conducted accordingly. We are getting credit hours without fail. So one question, sir, is it essential that they have to pay for this program any amount?
50 rupees, sir. That's what I said.
Everybody has to send to our
this action fund. Action fund with the details which I have told.
So kindly, all the participants, please be note that it is not enough that you are entering your name, your registration number, TNMC number, your email ID and phone number. Along with that, you have to send 50 rupees to our IMA Action Fund in the given bank account details. So kindly remember that also. Now it is time for us to get the felicitations from our leaders. I request our immediate past State President, Dr. Kanaga Sabhabadi, to felicitate this program. Dr. Kanaga Sabhabadi, sir. Dr. Kanaga Sabhabadi, sir.
Yes, sir. Good evening to all. Respected State President of IMA Tamil Nadu, Dr. C.N. Raja, Secretary Dr. Ravi Kumar, the CGP, the directors and secretaries and joint secretaries and members, and all other participants of this Zoom meeting. I'm very happy to see that our Professor Dr. Raghunandan is a well-known person to the medical fraternity in Tamil Nadu. He is not only proved his efficiency not only in the administration, he has proved his efficiency in the academic activities also. He is an authority for the infectious disease at the present. He has done enormous work in the pandemic COVID-19. I hope that his participation in the Zoom meeting is very helpful to us to update our knowledge. I once again Dr. Jayram, elected as National President, and Dr. C.S. Raja is elected as National Vice President, 21-22, and IMA CGP, National CGP Secretary Dr. Ambrose, and Joint Secretary Dr. Vega. So I hope that this program will help to all the numbers, that is, to enrich the infection control. Most of the members are lacking stick to
No, sir, your audio is not clear, sir.
I wish you all success for this program. Thank you for the opportunity. Thank you.
Thank you, Dr. Kanagar Sabapathy sir, for your felicitation. Now, I request our State President-elect, Dr. Ramakrishnan sir, to say his felicitation. Dr. Ramakrishnan sir. Dr. Vijay Kumar sir, is he available?
Ramakrishnan sir is not there, sir.
Sir is available, sir.
Ramakrishnan Ponusami. He is not coming, sir.
Not coming. So now I request Dr. Palani Swami sir, the State President-elect for 2021 IMA TNSP, to say the felicitation. Dr. Palani Swami sir.
Good evening to everybody. Respected State President, Dr. C.N. Raja, State Secretary, Dr. Ravi Kumar, and immediate past President, Dr. Kanagar Sabapathy, and the Director of Studies, Dr. Govindaraj, and Secretary CGP, Dr. Anbaraj, and all the delegates who had participated in this CME program. Very good evening to everybody. First of all, I congratulate our President-elect, vibrant President, Dr. C.N. Raja, have been elected as the National Vice President for the year 22. So I'm really happy that he has been elected, and we look forward more from him at the national level. And also at this juncture, I congratulate Dr. Jailal and Dr. Anbarase, Dr. Rekha for being elected as the office bearers of the national headquarters. First of all, I want to felicitate Director of Studies Govindaraj and Dr. Anbarajan for taking up so many new courses this year. Because immediate past Secretary of the CGP, I know how much difficult to coordinate with the doctors and faculties to run the course. But Anbarajan and Govindaraj and other office bearers has taken much efforts to see that the courses which are needed of the hour, that's the main thing, as our President has told and Secretary has told. Whatever courses needed, see now the courses needed is mainly infectious control disease. So that way they have taken up the very good courses, which is beneficial to the general practitioners and the hospital owners. So I congratulate them, Dr. Govindaraj and Dr. Anbaraj, for their efforts. They are doing it in this COVID pandemic time to encourage the members to go ahead with their work with the good knowledge they are imparting on them. And second, I just want to tell, as everybody has told, Dr. Kulandeswamy, I am just admiring him. Even he was the DPH, I came across and I have seen so many occasions his way of telling everybody how to control the infection, how to control the pandemic, how to control the diseases. And after that also, as our Secretary has told, he has not retired. Now only he is able to bring out so many short videos with the reporters, with the news in the newspapers and the circulars. And everybody is really benefited by that, by controlling the infection and what to do and what not to do in the hospitals as well as in the general practice. Really, we appreciate you, sir, for the great work you have done and you are going to do. Like that also, as everybody has told, Raghunandanan, and also I have come across so many times. He, along with our former DPS Kulandeswamy and other office bearers and other dignitaries in the government side, he has formulated so many things. And we have to thank him for giving a very good treatment to the COVID patients at the time at Rajaji Hospital and everywhere. His instruction he has given. And really, we are all thankful to Raghunandanan for everything. Even the people of Tamil Nadu is very much thankful to him for giving a very good guidance to treat the COVID patients in this juncture. And of course, everybody has told about Neminathan. Neminathan was looking after the nursing home board at Coimbatore. Immediately after I was in 2010, 2011, he has taken over the chairman of the nursing home board in Coimbatore, and he was from that time onwards, as well as I know for the past 15 years, any work he has given, as our secretary and president has told, he will do it to the maximum possible, to the perfection, that's I can say. Any doubt in vaccination, anywhere, any branch, not only in Coimbatore, any branch all over Tamil Nadu, when they are asking to give a lecture or deliver a note about the vaccination and what are all the possibilities for any diseases, he is ready to give. He can able to spend the time, and he is very much interested in that also. And really it is beneficial to all the general practitioners and all the branches in all over Tamil Nadu. So of course, these three are going to inaugurate this 2 days a new course, fellowship certificate in infectious diseases. Definitely it will be more beneficial to all the general practitioners and also all the hospital owners and all the members of the IMA Tamil Nadu State Board. So all this coordinating everything, we are for the past 6 months, I think from March onwards, for the past 6-7 months, we are meeting through Zoom, and we are hearing so many lectures. Means it is only because of Dr. Vijay Kumar. We have to give a big thanks to him. Because of him only, we are able to organize any meeting in such a virtual manner so that everybody got benefited. So our thanks to Vijay Kumar also at this juncture, and I hope all the participants will be greatly benefited. These three eminent personalities who are going to give about the infectious disease control program. Thank you very much for the opportunity. Thank you.
Thank you, Dr. Palaniswamy, sir, for your felicitations. Now, entering into the actual, program, infection control and management. Everybody has pointed out the commitment of the course coordinator and all the faculty members of this course. Dr. Neminathan, the course coordinator, and other faculties. Importantly, Dr. K. Kolandaswamy sir, and then Dr. Raghunandan sir, all of them have put their heart and soul in getting this course into existence. Tamilla ஒரு பழமொழி சொல்ற மாதிரி ஒரு கோடு போட்டா ரோடே போட்டுருவாங்க அப்படின்னு சொன்ன மாதிரி a very elaborative and very useful course was designed by them, which was very much essential for all the doctors, especially the general practitioners and small and medium-sized hospital owners in their practice. So now I welcome Dr. Neminathan sir, though a pediatrician in Coimbatore Child Trust Hospital, but putting his very much interest in infection control a lot. He did his UG and BG in Madurai Medical College. He stood first in PG in the university. He was past IMA Nursing Board Secretary of Coimbatore, IMA IAP Tamil Nadu State past Vice President also. Now he is going to introduce the infection control and management, our course, that fellowship certificate on infection control, infectious disease management and infection control. Dr. Neminathan sir.
Hello.
Yes, sir.
Hello.
Yes, sir.
Vijay Kumar, can I have the slides?
Yes, sir.
Respected Tamil Nadu State President Dr. Raja sir, my appreciations to you for becoming the National Vice President, sir. Your dynamic leadership qualities have shown a large, big role model for all the youngsters like us to be followed. Thank you very much for inaugurating the CME, sir. My dear Dr. Ravi Kumar, he is my classmate, very dynamic and a role model person. He has been instrumental in bringing out many programs like this, and my sincere thanks to him for his dedication and his down-to-earth hard work that has made him the state secretary, and my sincere thanks to him. Dear Kanasabhabadi sir, Dr. Ramakrishnan sir, thanks to you for the introduction. And our past president, Dr. Palanisamy sir, incoming state president, Dr. Palanisamy sir, very dynamic role model for all of us. And he is a leading person in IMA with a lot of leadership qualities. Thank you, sir. Thanks to Dr. Yasoda madam, Dr. Govindarajan sir, for taking up this fellowship course. And my sincere thanks to Dr. Andurajan sir, very dynamic person who has immediately kindled the energy in us to join together. And Andurajan sir deserves a big round of applause. My thanks to Vijay Kumar, the IT coordinator, who has taken up this project in a big way and then has been helping right from the beginning. My sincere thanks to Dr. Kulendesamy sir, who is my mentor for everything is because of his motivation. And my sincere thanks to Professor Raghunandan sir, Dr. Mohan Kumar, my fellow epidemiologist, and Dr. Suri Kumar, our team microbiologist. We 5 of us have joined together to start this fellowship course, sir. So let me go to the first slide. Next. So if you look at the problem, the background, the infectious disease is known to mankind right from the prehistoric period. So right before the mankind evolved, microorganisms were there. So if you look at the history, even before Christ, there were lots of pandemics and epidemics that going on. That one of the main reason why our population is limited is because of the microorganisms. Had these microorganisms not taken place, our present population would have been 100 times more than what is now. So we've been facing such potential problems right from the beginning. And as you know, zoonotic diseases, the disease we get from animals, even this COVID is a zoonotic disease. Every 5 minutes, one zoonotic disease happens throughout the world, every 5 minutes. Fortunately, 99% of the zoonotic diseases are controlled by within the community and they don't spread out. Rarely, some zoonotic diseases like swine flu that happened in Mexico a couple of years back, that spread to almost nearly 168 countries. Now the COVID has spread to almost all countries. These are the zoonotic diseases that are most important disease that causes pandemics in the world. So this COVID-19 is also a zoonotic disease, which we got it from bats. Next slide. So now we have lots of emerging diseases, and some of the diseases which were past, now they have started coming back again. As you know, cholera is once again coming back. Many diseases like brucellosis is coming back. Anthrax is going to come back. They're all biological weapons also. So many diseases, which was a disease of the past, is coming back. So we need to increase the level of our knowledge so that we tackle with newer diseases and also the past diseases which you have learned in our undergraduate curriculum. We need to revise them, and then we need to form a current strategy. And also adding fuel to the fire, you can see the international travel, which has been a big menace to the spread of the disease. In fact, even this COVID-19 spread to many of the European countries and US because of the delay in the control of the international travel. So luckily, the government of India, both central government, state government, took initiative measures in having the control of the incoming flights into our country early. That's the reason our pandemic was well controlled for the past 6 months. That is one of the main reasons. Next slide. Even non-communicable diseases, persons with obesity and other non-communicable diseases are at a higher risk of morbidity and mortality due to infections. Even a non-communicable disease, what you think is not a infection by per se, but these persons with NCDs are at a high risk of getting infected, and if at all they get infected, the mortality is also very high. You would have seen in COVID also, people without non-communicable disease had a less mortality, whereas people with obesity or lifestyle diseases had a higher mortality. So I already told you about the global emerging and re-emerging infections. Please go to the slide. If you look at the history past, almost every 17 years one pandemic has happened, every 17 years. Once in 37 years, a big outbreak has happened, causing a worldwide problems. The last one we had swine flu pandemic 100 years back, what's called Spanish flu, almost had a very high mortality on throughout all the countries. If you look at two cities, Philadelphia and St. Louis, 100 years back, Philadelphia did not have a fixed program, whereas St. Louis was a disease that had a structured program in which they were able to mask everyone. They followed social distancing. They stopped gathering in public places. And the outcome of St. Louis was the mortality was very less when compared to Philadelphia. The same experience, Philadelphia, St. Louis experience, now we are extrapolating in the entire world. So next slide. Next slide. So the need of the hour is to educate our undergraduates, particularly general practitioners, about infectious disease for the early recognition, very, very important, and appropriate investigation, timely investigations under better management protocol that is standardized. Throughout the country, we'll have a standardized management protocol for all the diseases. And also mainly, the public health has a big impact on this, and then controlling the infectious disease in a bigger way at the beginning stage itself will help us to overcome the future pandemics. So updating the knowledge according to the trend, in particular disease through CMEs on short-term courses which are going to come out as fellowship course in infectious disease, that will help the entire country. So coming to the fellowship certificate course on infectious disease and infection control, I like to thank once again Dr. Anburaj for initiating this, and our mentor, Dr. Kulandeswamy sir and Raghunandan sir. Friends, we are going to start this course for IMA doctors, particularly general practitioners, to constantly update the knowledge and increase the clinical skills on infectious disease, and to create a platform for continuing medical education for general practitioners continuously. Even after the course, this platform will be live, and we'll be having a continuing medical education programs for the doctors who are registered in this program. And then definitely this will have a big impact on the outcome of various diseases pan-India level. Next slide. So this course is going to be, at present, is going to be online. The duration of the course is going to be 6 months. Next slide. So prerequisite is that you have to be a member of MBBS and then member of Indian Medical Council and a member of IMA. These are the three main prerequisites. And as I told you, we'll right from anatomy, physiology, microbiology to right up to the diagnosis, management, and prevention. Everything will be dealt in detail through the various experts in various fields. And then at the end of the course, you will be coming out with a highly knowledgeable group of set of doctors who can manage in their own clinical setting. For example, in a remote village, a general practitioner can do a best work what is done in a big institute. So that much of knowledge will impart to the doctors, and that will be definitely reflecting upon the entire society. Next slide. And I like to thank my team core committee members, Dr. Kulandeswamy sir, well-known person, past director of public health, who is beginning this show, is the backbone of this our fellowship certificate course, and Dr. Raghunandan sir, who is a professor to many of us like me. He is a very guiding example of lots of newer modalities in the management, and he has done a very good service for the COVID patients. My appreciation, thanks to you. And my sincere thanks to youngsters, microbiology professor, Dr. Suri Kumar from Madurai Medical College, who will be helping us through various, right from microbiological aspect of the agents, microbes. Thank you, sir. And my thanks to Dr. Mohan Kumar, who is an epidemiologist. And he is also ICMR, he is an expert in that. So thanks to Dr. Mohan Kumar, who is a big backbone in forming this organization and helping us in various IT activities. Thank you, friends. And now I hand over to Dr. Pulandeswamy and Dr. Raghunandan for today's program. Thank you.
Thank you, Dr. Neminathan, for introducing the course and all the persons involved in a very effective way. Really, it's a combined effect of all the persons noted by our Dr. Neminathan. Really, I was really very much wondering how they have been putting their heart and soul into this, developing this course. Now I request Dr. Pulandeswamy sir to start the second session, risk reduction strategies. Really, everybody appreciated Dr. Pulandeswamy sir very much because of his simplicity and commitment, and even after retirement, continue his commitment to the public and also to his colleagues who are in government as well as in private practice. Thank you very much, sir, again for your involvement. You have started involving in IMA activities too. As such, he has started his career as a medical officer in Nilagiris, Nadu Primary Health Center, the year 1993. And then he became a health educator of Institute of Public Health. Then he became Deputy Director of Health Services in Vellore, and then Deputy Director of Health Services, Deni, and Reproductive and Child Health Project Program Officer, then Public Health Preventive Medicine Director, Deputy Director. Then he did his Masters in Applied Epidemiology in Chennai National Institute of Epidemiology, and become the Joint Director of Public Health and Preventive Medicine, Epidemics Control, and Additional Director of Public Health and Preventive Medicine in the year 2012 and 13, and Director of Public Health and Preventive Medicine in charge in 2013, and he has become finally the Director of Public Health and Preventive Medicine, and for 7 years he has done a very wonderful work, and which was appreciated by all our leaders. Really, we are having a very energetic person in this course, who is having a lot of things to tell about the papers published him and the major projects he has undertaken, like 104 Health Helpline, 24/7 Control Room of Epidemic Control, and so many other things are very much notable one. His contribution to the health, public health, is being appreciated by the government of Tamil Nadu and government of India a lot. So we are, because of constraint of time, I'm restricting all these things. We know about Dr. Pulandeswamy sir. Now we are going to hear from him the topic risk reduction strategies. Dr. Pulandeswamy sir.
Good evening to all of you. So I'm thankful for the IMA and the IMA College of General Practitioners for giving us this opportunity to do this program. Actually, from 2012, Dr. C. Rajendran, Dr. Raghunandan, Dr. G.K. Dureraj, and myself, and Neminathan, there is a list of post of resource persons moving across the state and conducting courses mainly on, not courses, CME programs on fever, particularly fever management. And now after long years, thanks to the President and Secretary and the Kanburajan and other office bearers of IMA and IMA College of General Practitioners, now this has become a reality that we can do it in a very organized manner. Once again, I thank all IMA members and IMA College of General Practitioners. Shall I share screen or
Yes, I can share.
I can share. Okay.
Yes, sir. Yes. I'm back.
Sibyl, sir?
Yes, sir. Yes.
Okay, sir. So actually these slides, I think as mentioned, I think many of you might have seen earlier, but here I am reduced the content to only very focus point, that is the risk reduction strategy by in particular to healthcare facilities. We know these viruses are of animal origin. 4 human coronaviruses are common cold and 3 cause severe acute respiratory infection. So 2002, it came from the civet cats in China, so that now it is called as SARS-CoV-1. And 2012, from the Somali or Arabian camels, it is MERS-CoV, Middle East respiratory coronavirus. And currently 2019, initially it was called as novel coronavirus. Now it is called as SARS coronavirus 2. It came from the Wuhan city of China, then it spread to Hubei, then rest of the world. And we know the symptoms: the loss of smell, fever, rhinorrhea, sore throat, sputum production, new continuous cough, loss of appetite, body pain, fatigue, headache, diarrhea, and the shortness of breath when walking. So I'm not giving importance to breathlessness, because it is a symptom which appears very late. So waiting till the breathlessness appears will be too late. This one we need to emphasize to the people. So as we know, the transmission is airborne and handborne transmission. Handborne, so directly through hugging, handshake kind of activities, and indirect through various articles and contaminated hands, that is surface contamination. So here the WHO, World Health Organization, has recently issued this slide. This, I think we are also experiencing the same thing. So triple C's, like our COVID care center, triple C center. So here the triple C means crowded places. Crowded places is the main the reason for the spread of the infection, and then close contact, particularly more than 15 minutes. Then confined and enclosed spaces. So if you look at, then there are in some situation, these 3 C's may be overlapping. If it overlaps, then the risk is very, very high. So now, of late, there are 2-3 situations have emerged as a major transmission. So one is hospitals. The hospitals, particularly the unnecessarily visitors and attenders, they are the main reason for bringing the infection or taking the infection from the healthcare facility. And this is evidenced from the antenatal mothers are positive. When we interview the antenatal mother, positive antenatal mother, I had gone for a consultation. Someone, my mother-in-law, she went for to see someone in the hospital. And the other reason is my husband tested positive and I am also tested positive. So these are the major source of infection for the antenatal mothers. So that is generally the antenatal mothers, generally they don't go out during the last trimester. So it is a reflection of the reality, the ground reality in the field. So as we know very well, the virus enters through the eyes, nose and mouth. So here the 2 slides, why infection control is very, very important at this hour of crisis, because we need to bring in a new norms, new lifestyle for the patients, how to behave, patients and attenders, how to behave in their when they come to a health facility. If we don't bring in a kind of discipline among the patients and their relatives now, then after this pandemic over, it will be very, very difficult. And also why it is very important to bring in such kind of discipline or the new norms in healthcare facilities, because the pandemic will be over or the epidemic will be over in the next 1 or 2 months. But clustering of cases or sporadic occurring of the cases will occur in for another longer period, at least for another 1 year. So that means immediately the individual will seek care in a healthcare facility, maybe a small peripheral clinic or a mobile health unit or a PSC. Then subsequently they come to a major hospital for investigations or further treatment. So that means the healthcare professionals and the other patients in the hospitals will continue to be at risk till the infection is completely controlled. So that is the reason that this is the time. After this pandemic is over, then bringing a discipline among the public will be very, very difficult task. So this is the ideal time to discipline the patients. So the 555s, this we have told in many of the meetings, but anyhow, the transmission prevention for one area, and another area is increasing the immunity, and another area in case of symptoms, what we need to do. The universal face mask, hand wash, disinfection, social distancing, and ventilation. These are the 5 key result areas for preventing the transmission. Then enhancing the innate or inherent immunity, good nutrition, Ayush including pranayama, then control of comorbid conditions, good sleep, that is very, very important. Then smoking, quitting smoking is very, very important. Then when the symptoms appear, often the problem with the doctors and nurses and other healthcare personnel, we don't seek care immediately. We try to treat ourselves. That is the major issue with doctors. So immediately consult another doctor, maybe a colleague or friend or whoever it may be. Then check for the SpO2 level, temperature check. Then definitely without hesitating undergo RT-PCR test. One of our health officer, whenever he got exposed, whenever he had a mildest doubt, he had undergone RT-PCR testing 10 times. The 10th time he tested positive. So, but for his inquisitiveness, then he would have landed in a lot of trouble. So, don't hesitate in getting tested. That is very, very important. Then early treatment, that is also very, very important. So now, the key points for infection control, the new norms, whether it is a school or a shopping mall or a healthcare facility, we need to follow the new norms. So here what we fail to understand, particularly the doctors in the healthcare facilities, we assume that the mask, the personal protective equipment will give the 100% protection like a deep sea diving suit. It is not so. So the efficiency of the face mask, the efficiency of the PPE will increase only if we practice the social distancing and avoiding close interaction, then washing hands frequently, at least 10 to 15 times, whether we are in the hospital or at home or outside, then good ventilation, disinfection, depending on the number of patients and the movement, then we have to decide the number of times that we need to do the disinfection. So in every hospital, so you can put a fire mat in every building. So before entering, so about 4 to 5, 6 steps, they should walk over a mat which is sprayed with hypochlorite solution so that the street chapels get disinfected. So it is very, very important. Depending on the situation, hourly or 2 hourly, it can be the hypochlorite solution can be sprayed. It is a fire mat on floor. Nothing will happen. You can use it any number of times. Then walk paths also need to be disinfected. That is also very, very important. Then at the entrance of the health facility, entry and exit hand wash. Nobody should enter the hospital without washing the hands and also exit without washing hands. Face mask, temperature screening, SpO2 measurement. It should be like a security checkup. And we know the normal body temperature. So the advantage of screening with infrared non-touch thermometer is it is non-touch and it detects fever much earlier before the individual feels that I'm likely to have fever. It appears that I'm having a fever So that is the advantage of testing with the infrared non-touch thermometer. So 37.2 degrees centigrade, anybody is testing screened above 37.2 degree, they should be isolated and tested. They should be triaged. The hand wash before, this is in an urban primary health center in Trichy. So many hospitals have, you can see the Madurai Medical College, many of the private hospitals in Madurai, you can see, I have seen in several other places also, they are having hand wash installed in multiple places. The wards before every building, casualty, CME entrance, and parking lot. So everywhere, many places, depending on the number of the beds or the hospital size. So 10, 15 places. The Madurai Medical College, they are having at least some 30, 40. They are having before the nursing hostel, before the house surgeon hostel, PG hostel, everywhere. In fact, in every ward, before entering or before leaving, people need to wash hands. That is very, very important. So unfortunately, we are not understanding the importance of washing the hands. And then again, the next one, which we fail to understand, is the effect of ventilation. See, here you can see the open doors and windows. So although this person is sneezes or coughs, in multiple direction the wind dilutes immediately. When the air change per hour is more than 12, hospitals ideally it is 20 to 24. So immediately it disperses. So this person, the other person is not infected. But when the doors and windows are shut, so it immediately spreads the entire room. And since these are very micro, minute droplets, these droplets will continue to float on the air for several hours. So the next person comes also getting infected. So this is the difference that we should understand. Keep all the doors and windows open, and hybrid ventilation. We can use the hospitals. You can use this kind of powerful exhaust fans, and you can use pedestal fans. You can use the smaller exhaust fans in bathrooms and other places. This is very, 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 very important. So which we are, but at the same time, we should place the direction of the air mount in such a way that this doesn't transmit, the air current doesn't, you place the air current in such a way, it is always moving outwards, not inwards. This is very important. So here, please understand, from the government side, so thousands of camps are conducted every day, but all camps are conducted in open places. No camp is conducted in closed places. Disinfection, then face mask, hand sanitization, hand hygiene, and then periodical disinfection you can find. So despite all camps are conducted in containment areas, fever positive areas, but you will find surprisingly there are very few infections. That also we are not sure whether the infection came from the camp or the infection came from elsewhere. Then this is outpatient arrangements. So many of the doctors are now doing outpatients outside the PSC. We are conducting daily meetings in open space. Nothing happens. So the ventilation is very, very important. The antenatal clinic, the mothers are tested in a separate building. They are not mingled with other patients. Either separate the time scheduling or allot a separate area. Then instead of the table, instead of the tablecloth, so this is a plastic sheet. So it can be easily wiped, or it can be disinfected easily. And the tables also, these are the lightweight dining tables used. So these are the tables in many of the primary health centers. They are used in their OP, or they are using when they go for the camp. Then this is a medical officer room. You can see both the windows are open. So you can see the pedestal fan. So the patient sits here at a time, only one patient. The doctor sits here. So 6 months continuously he is treating fever cases. Nothing, neither he nor his staff are infected. This is the hand wash facility, and the bathroom is this side, right side of his room. Always the exhaust fan is also running. So this is how a room has to be, the consultation room has to be arranged. So you can see the exhaust fan, and again wash basin inside the bathroom. Then elevators are the highest risk. Minimize the use of elevators in the hospitals. One floor, please climb, and even 2 floors or 3 floors, healthy can come down. And again, the hospital pharmacy, if you go to many of the hospitals, the hospital pharmacy, even somebody who is coming and buying a medicine from outside, they also need to come inside the hospital. They don't have any separate, some hospitals, they have both side. Outside people can collect, can buy drugs from another counter, which is directly opens outside, and the hospital people can buy drugs. The people who are inpatients, particularly inpatients, don't give prescription and send the attender to the pharmacy. So the prescription can be sent directly to the pharmacy, and they can send medicines to the room or the ward. Then similarly, the laboratory. So the patient should not be sent to the laboratory. So only the samples should be sent to the laboratory wherever possible. The staff nurses can be trained well to take samples. Then similarly, the lab technician who are going for home service should be screened thermally before going for sample collection. Then the cash counter, again, this is another risk. After doctor takes the rounds and discharges, then everybody queues up in the cash counter. So the cash also for the, particularly for the inpatients, the cash also can be collected in the rooms itself. Some kind of innovative arrangements need to be done. And another major challenge comes from the patient caretaker. Allow only one healthy relative or friend. Don't allow more than one person. And the one person, the same person should stay back from the time of admission to discharge. Anything need to be bought outside, they can, the other attender can give at the gate. This person should not be given a pass. No visitor pass, no attender pass. Attender pass means, so he will, with the attender pass, he will move around and to the nearby shops, to the nearby places. So then it becomes a serious problem for the hospital as well for the community and also the patients. So only healthy patient caretakers to be allowed, and visitors, there is no need for any visitors. They can talk over phone. If it is a birth companion, then again there is no need. Only the mother or mother-in-law without comorbid condition, they can be permitted. If they are having comorbid condition, sister or sister-in-law, so younger age group who are undergone motherhood and be permitted. So the pregnant mother should get tested 5 days before the EDD. The village health nurses, we are continuously training to educate the mothers. குழந்தையும் அம்மாவும் வந்து வீட்டுக்கு டிஸ்சார்ஜ் ஆகி வந்ததுக்கு அப்புறம் the visitors, relatives, friends can come to the home and see the mother and child. So then again the use of broomsticks. So try to slowly change the hospital cleaning to wet mopping and also the vacuum cleaning. Broomsticks should be totally avoided. Hospital garbage also should be disinfected. Then decontamination of linen and the clothes in the hospital, 1% hypochlorite or 5% Lysol. Then washing clothes at home, then half an hour soaking in the detergent. If you're washing with the machine, do not use the speed option, add slightly more detergent. If the hot option is there, you can use hot option. Many of the hospital staff, they come from the containment area, somehow they come to the duty. That should be avoided. And the hospital staff, they themselves are having cough, cold, the symptoms, they don't test themselves. They simply for attending the duty, they come. So they educate the staff and families about when they should stay home and when they can return to duty. This is again major problem. And another major problem for the doctors, nurses and other paramedical staff, they are carrying bags which are not washable. Either they should carry a cloth bag or lunch carrier or a basket like this, which can be washed along with the lunch carrier. This very, except the mobile phone, nothing should be taken from the hospital to home, and similarly from the home to hospital. This is for doctors, nurses, for everybody. You can have, suppose we are having 2-3 places consultation, or at home you can have a separate clinical tools. In another place, so 2-3 places means 2-3 separate. Nothing, don't carry anything in car or bike or in your handbags. So only mobile phones. So except mobile phones, don't carry anything. That's very, very important. Then screening of healthcare personnel. This is also we are repeatedly telling. say blood sugar, pressure. Those who are not undergone screening, they should get themselves tested, and also the chest auscultation for respiratory or cardiovascular diseases. All the healthcare staff daily at the time of reporting for duty, they should be screened for the temperature. They should be screened for the SpO2 level. Any sickness among the staff should be informed immediately. Then if you look at who is patient X, people who are not aware of the healthcare facilities and control room number, people who are seeking care very late. This is the most important thing. Then people with untreated comorbid conditions, particularly diabetes, hypertension, kidney disease, liver disease, and bronchial asthma. Then failure to monitor SpO2. Many times the home care patients, the patients who tested negative, there is an exposure history, but they tested negative. Even such patients need to be, this is a major problem, because this RT-PCR may not capture all cases. All positives are true positives, but all negatives are not true negatives. There is an epidemiological linkage, clinical correlation. Then you need to consider such patients also as a potentially positive case, subject to X-ray, CT, biochemical, and continuous monitoring. Then smokers, if any of the healthcare personnel is in the habit of smoking, they should immediately quit smoking. Within 12 hours of quitting smoking, the carbon monoxide starts leaving. Within 2 days, the dried up secretions become moist. Within a week or so, the cilia again starts regenerating. So even if one quits smoking, it brings benefit. And the very important item, never ask home care positives and epidemiologically linked but lab test negative persons to seek care when symptoms for breathlessness occur. It is too late. Breathlessness occurs only the SpO2 level goes below 80% or 70% and so. Then again, the negative persons, epidemiologically linked persons, and positive people don't hesitate to write the all kinds of tests: diabetes, hypertension, respiratory illness, oxygen saturation, blood test for biochemical markers, X-ray, chest, CT, ultrasonogram abdomen if indicated. Then clustering. If any of the doctors notice clustering, that in a particular street or village or a particular area, so that means the deaths will start occurring. If you don't organize aggressive control measures, you immediately inform the DD Health or the city health officer. And again, the psychosocial well-being of the doctors and nurses also, it's a long, this is a situation more than 6 months. So the doctors and nurses are continuously battling in a very difficult situation. So say good words, encouraging words, and keep the morale up. That is very, very important. So be concerned about their welfare, then encourage staff who are consistently following the protocols. Then everyday preventive actions by everyone will save the situation. But this is an opportunity although this is a very difficult situation, this is an opportunity to bring in discipline among the patients, how they should behave when they visit a healthcare facility. Thank you very much. Thank you.
Thank you, Dr. Kolandesamy sir. None other than you cannot represent this in a very simplified way like this. Really, you are great teacher also, not only having a concern for the public, but you are a very good teacher. And really, all those who are attended today, more than 100 people, they are really a blessed one. So my humble request to all the participants, this infectious disease management and infection control course is being coined in such a way that all the, our IMA CGP members, general practitioners, has to be benefited a lot. So the small and medium-sized hospitals should get benefited. And a lot of other additional inputs and additional helps they are planning to give for those who are registered with us for this course. So really, this course will be of much useful for you to protect you first, then your staff, then the public. That is the way the thing is fine. So the risk reduction, it is not for corona only. It is how to practice this all through our life. All through our life, we have to have this risk reduction strategies. So it's very useful. That you have to get. Immediately you register yourself whoever want this course and get. You get your name registered for that soon. Within 2 weeks, the course will be started. Within 2 weeks, the course will be started. Now we are moving to the third session. What is unique about COVID-19, which is known to a doctor as a general practitioner? It is none other than Dr. S. Raghunandan. The Professor of Medicine, Institute of Internal Medicine, Madras Medical College, and physician Rajaji Gandhi Government General Hospital, Chennai. Done his MD General Medicine and PG Diploma in Higher Education, and then MBA in Hospital Management also. He is a Chief Physician in IMCU and Toxicology Unit, Deputy Superintendent of Rajiv Gandhi General Hospital in Chennai, and State Nodal Officer for COVID-19. He is Medical Officer in charge of ERT, Chief Coordinator of Medical Education Unit, and Chairman Board of Studies for Final Year MBBS, Resource Person for Curriculum Development in Tamil Nadu, Dr. MGR Medical University, and Member State Rapid Response Team for Infectious Diseases, Member Local Research Advisory Committee for Multidisciplinary Research Unit, Member National Study Group of Snakebite, a Chairperson for Ethic Committee in Sri Ramachandra Medical College and Research Institute, and Member Academic Board of Studies, Chettinad Medical University, and a lot. So it's going on. So really, we are having a very, educated and a very responsible person who is going to tell us about the unique COVID-19 situation, which we all should know. Let me invite Professor Dr. Raghunandan sir to start his presentation. Dr. Raghunandan sir.
Thank you, sir. Thank you. Am I audible?
Yes, sir.
Very much audible, sir.
Just a minute, sir. You click pantuma. Share
Sir, right side blue button. Share no blue button.
Sir, full screen vandircha?
Vanilla sir, share panning sir, no ninge. Na share panning sir.
Share varliya?
Na share varliya sir. Kila green button click பண்ணிக்கலாம் sir. Share screen.
ஒரே நிமிஷம்.
Sir, kila green color button.
Green color.
Click பண்ணப்போ ஒரு window open ஆகும் sir.
Share. Yes.
Yes. Yes. Oh.
PowerPoint எங்க வருது?
Yes, sir.
Yes, sir. இந்த ஸ்கிரீன் எடுக்கிறோம். இது மினிமைஸ் பண்ணிட்டேன். Okay. Am I audible, sir?
Yes.
Good evening, all. First of all, I thank the IMA for organizing this meeting. Respected State President, Mr. Dr. Raja, Honorary State Secretary, Dr. Ravi Kumar, past presidents, Dr. Kanaga Sabapathy, and immediate state-elect president, Dr. Ramakrishnan, Dr. R. Palanisamy, and our office bearers of the state branch and the local branches. Also, my mentor and my guide, Dr. Kulandai Sami sir, Dr. Neminathan sir, and other friends who have joined the Zoom meeting today. Greetings to all of you. And also, I thank all the previous speakers who have said some good words about me. Today, I think when this program was conceived and we were just discussing about the title of the on what subject we can start with this today's program. And when Dr. Kulandai Sami sir said we should talk about COVID-19, I said immediately, sir, now all the doctors, including the public, are fed up with this COVID-19. In fact, when we say doctors that COVID-19 is going to be spoken, they are getting fatigued. But he said, no, we should do it, but we'll do it in a different way. So that is why this concept of what is unique about COVID-19 and what we must know as doctors. Again, my talk, again, I'll make it clear. This talk confines to the primary care physicians who are handling the nearly 85% of the patients in COVID, as far as COVID is concerned. So what I am trying to do in this 15 to 20 minutes talk is whatever we have learned, it's a continuous process, all of us know. Whatever we have learned so far, I am trying to edit it under different headings. And as a primary care physician, what we should keep it in our mind when we are going to practice. So we'll discuss, and I'm sure that most of the points may be known to you, but I'm going to do it in a little bit different way. What we call it as knowledge, understanding, and application. You know something about the virus, okay, fine. Well, how it's going to help me in my practice, or how it's going to help the patient. So with that concept, knowledge, understanding, and application, I will just go through the presentation. I think the best teacher of the year 2020 goes to Corona. I think everybody will agree on that point. And we have learned many lessons since January 16th. We still remember the first case as far as our state is concerned. We admitted in Rajiv Gandhi Government General Hospital. And since then, we have been learning every day. And again, one of the doctors said it is like Newton's third law. Whatever we learn today, immediately the opposite view comes immediately within 1 or 2 hours to counter that. So it's like a Newton's third law. We are learning every day, and we keep learning over a period of time. So before I start my presentation, I'm just making myself clear. What we know about COVID-19 is little. That also keeps changing every day, and no consensus on many issues. Okay, so my talk, what is unique about COVID-19? We are discussing under different topics like epidemiology, clinical features, diagnosis, management, complications, post-COVID status, and vaccination. As I said, we are just going to highlight the important points. We will be not going to the entire aspect of each topic. And maybe at the end of the session, we can have a question answer session. If you want any other clarification, we take it. I think this is a slide already Dr. Neminathan sir also spoke about that. We are going to live in an infectious disease world where 65 to 70% of our infectious diseases are going to be zoonotic. You name an animal, we have an infectious disease as a source of infection. In this particular slide, you can see the SARS-CoV when it came in 2000, early 2000, the civet cat was the culprit, and then it became human transmission from the cat. And when it comes to SARS-CoV-2, it is a pangolin, which is supposed to be the source of infection to the humans. And of course, for the MERS-CoV, we all of us know it was a camel. So the WHO, World Health Organization, has clearly come out with a concept called One Health concept. Today, when we are talking about human health, we cannot isolate human health as a separate subject. It should be with people, it should be with the healthy environment, and also with the healthy animals. If you look into this particular slide, it tells very clearly how the infectious diseases, especially the zoonotic, come in contact with the human population. For example, if you can see here, the few animals are there, and through vectors or maybe a direct thing, there is a spillover to the humans. So this is a point which all of us should remember, that once it enters the humans, No longer we need the animals for the maintenance. So it is a human amplification. That means, for example, if you take corona, we say it has come from the pangolin, but once it enters the humans, human became the source of infection, and today we are facing a pandemic where human to human transmission is going to be the challenge. Again, this is a very interesting slide to know how our understanding and technology has improved over a period of time. How we have responded to a pandemic. For example, you take HIV, which was a well-known pandemic which all of us have faced or facing. For example, recognizing the outbreak was in 1981, and the etiological agent they could find after 2 years in 1983. Diagnostic test came two years later, 1985, and antiviral, anti-ART came into vogue in 1995. So it almost looked into again, the vaccine is still, we have not found. So if you look into the chronology of events for HIV, it took almost 15 years to achieve what we are now achieved in few weeks or few days. You just look here. As far as COVID is concerned, the outbreak was recognized somewhere in late December of 2019. And 10th January, it's a matter of 20 days, they could identify the etiological agent and genetic sequencing they could achieve. And again, that helped us to develop the diagnostic test in 12th January 2020. So within a matter of two weeks, we could achieve what it took nearly about 10 to 15 years for HIV. But still, therapeutics, for example, the well-proved drug for COVID is still not found, and still the vaccines are only on the trials phase. Again, you just look into the how we are comparing the present corona COVID-2 with other similar viruses which have occurred before. For example, SARS came in 2003 and it had a fatality rate of around 11%. If you look into the transmissibility, it is just 1+. That means it is very less transmissible, but significant mortality. The same thing if you look into the MERS. MERS, if you look at the fatality rate, it is 34%, but transmissibility is less. Now the course SARS-CoV-2, if you look into that, you are seeing the fatality rate is around 1% or less than 1%. But just look into the transmissibility. Transmissibility is 3+. That means this virus is very effective in transmission, but less in the mortality. So everybody is asking what next. So maybe we will not be surprised if you are going to get SARS-CoV-3 or SARS-CoV-4 in the near future, with the disadvantage of both the things. For example, if the virus is going to be highly fatal, highly transmissible, we had it. So we have to be very, very vigilant. That is where CME programs like this will help us. So we have to be very, very vigilant. I still remember when we used to take classes for H1N1, I used to show a person that all the doctors, nurses are wearing a PPE and handling a patient. Everybody used to laugh when I show that slide in the end, but today it is happening. So our orientation and our understanding towards infectious disease should keep on updating ourselves. Again, this is a very interesting slide to justify what I have been saying. If you can see the X and Y axis, if you see, this is the mortality side. That is the X axis. You can see the MERS, bird flu, Ebola and all, they are highly fatal. But if you look into this side, for example, measles and the chicken pox, their transmissibility is very high. That is, we call it as RO number. All of you know that. So if the RO number is less, means they are less infective. So our corona stands somewhere in between the MERS at one end and the measles and chicken pox at the other end. Okay, so we are just, I think Dr. Kulandaswamy sir has shown a very beautiful slides on how to reduce the infectivity. He was showing one clinic with 2 windows on either side and with a wash basin in on the wall, and maybe a pedestal fan to reduce to improve the air circulation. In fact, this question was asked, why the general practitioners are more prone for this COVID business. I think most of us will agree that most of our clinic, if you enter a clinic, it is a closed door environment. There will be one door for the entry. There will not be any, windows for any circulation. Invariably, it will be air conditioned. So just look at the risk factors. It's an indoor, yes. Lack of ventilation, yes. Air conditioning, yes. Crowding, again, our OPs In most of general practitioners, they'll be seeing around 100 plus patients per day. So crowding is there. So this is an ideal environment for the transmission of the COVID-19. In fact, in the city of Chennai itself, we have lost some leading private doctors, private practitioners because of this COVID-19. And we are what the message is very simple. Please make sure that all the clinics are well ventilated. Even if it is air conditioned, keep one fan behind you so that the air goes out of the room frequently. Otherwise, the same air you are going to inspire and expire, chances of getting infection is high on the cards. Of course, another thing, now if you are wearing a PPE, please follow the protocols, because one of the reason, even if you wear a PPE, if you are not wearing it properly and removing it properly, you are at risk. So breach in the protocol is also a factor for why our doctors are getting infected. Again, any talk on the COVID-19 cannot be completed without going through this particular slide. It has got everything a doctor should know as far as COVID is concerned. I will not go into everything. I'll just tell only one important point. If you look into this particular slide, it talks about two important things. One is a viral responsive phase. Other is the host inflammatory response. So if you look into the host inflammatory response, it keeps increasing from the end of first week till the 2 to 3 weeks. If you look into the viral response phase, it is maximum to start with, and as the days goes, it comes down. So the message, what is trying to tell us is, again, normally when we address the doctors, we say virus, as far as COVID is concerned, virus does not kill the patient. It is the host respiratory response or the post-inflammatory response that kills the patient. So that is an important point that I wanted to tell. Again, you can see the different phases. For example, what we call it as stage 1 is the early infective phase. Then the patient goes to the pulmonary phase, and finally hyperinflation phase. I request all the listeners to just have a registration of this particular graph, so that when we discuss the subsequent slides, I'll try to relate those points with this particular slide. I am happy to see the count has gone beyond 100. So today, I think we have scored a century in this CME program. So when you are talking about mode of transmission, again, I was telling that the concepts keep changing. When we are discussing the transmissibility in somewhere in February, we are talking more of fomites. Don't touch that, don't touch this, immediately do hand washing, all those things, but still it holds good. But today, the airborne transmission is the most important, and the fomite transmission is not so much that we have learned over the period of 6 months. Similarly, the fecal-oral transmission possibility, but it's not the mode of transmission we see. Again, mother to child and animal to human transmissions, we have already discussed. But some of my patients, they come and ask when they have pet animals whether my dog will be infected from me. They are now worried about the reverse transmission also. Okay, again, this is a very important time. So many people are asking me, sir, why you are talking about mask, everything. I think mask is the best vaccine. If at all you want a good vaccine, wearing a mask is the best vaccine. If you look into the thing, if the person is a carrier and the next person who is a healthy adult alone is wearing, but this fellow is not wearing, transmissibility is around 70%. And if the infective person is wearing a mask and even the normal person is not wearing, then it comes to 5%. If both are wearing, it comes to 1.5%. So what is the message it tells? Unless all the people in the community wear a mask, it's not going to help the cause. For example, we know the patient becomes infective 2 to 3 days before the onset of symptoms. So today, even if I don't have a symptoms, I may be infective, which I may not know. So please, when you interact with public and your patients, please tell this message that even if you are asymptomatic, you may be having the virus, means you will be giving to other people up to 70%. Okay, now coming to risk factors. As far as risk factors is concerned, you already, sir, has also discussed old age is a definitive risk factors. And I should say at this moment that this virus is gentle to some extent with pediatric age group as well as to pregnant women. Because when we discuss about the dengue and H1N1, definitely we have seen that pediatric dengue are more common, pediatric H1N1 are common. But now, even though we do see some pediatric cases in the community, compared to old people, they are very, very less. As far as cardiovascular risk, of course, hypertension, ischemic heart disease are very, very important risk factors. Next, about the diabetes, I think most important diabetic risk factor happens to be diabetes, and also controlling the blood sugar or detecting diabetes when COVID is there is also very, very important. So in our diagnostic test, routine blood screening for blood sugar is very important. Again, as far as respiratory disorders, please remember that Government of India has given a very clear-cut guidelines. All COVID patients should be screened for tuberculosis and vice versa. All TB patients should be screened for COVID-19 also. Again, malignancy, chronic kidney disease. Since short of time, I'm not going into the other components. Please remember obesity. Obesity, if a patient is obese with COVID positive, chances of complications are much more than. Again, there is a very interesting article in New England. They have found out which professionals within the medical professionals are at high risk. I think the number one goes to general practitioners because they do see more patients. They are in already the factors I have enumerated. Next comes the intensivist, dentist, ENT surgeons, of course, nurses. These are the orders of infectivity among the doctors. So now we have discussed in detail about the epidemiology. Now we'll go to the clinical features. I think Sarah has also mentioned. So we go by the asymptomatic, mild, moderate, severe, and critical phase. And the slide is self-explanatory. This is where the role of primary care physician is very, very high on the cards. For example, we know around 80 to 85% of our COVID patients can be managed at home or at the CCC, that is Corona Care Centers. So as a primary care physician, it's your duty to inform and educate the public, also your patients, that if you're asymptomatic, don't worry, you can be at home unless you have other risk factors, and you can appropriately advise them regarding the isolation, regarding the checking. I think what we need is temperature, pulse, blood pressure, respiratory rate. Most important is your pulse oximeter. I think today, just like thermometer in every house, I think better that you have a pulse oximeter also in everybody's house so that they can check the pulse oximeter. And of course, the X-ray is normal, you can manage at home. Mild symptoms, again, you can manage if you don't have a risk factors. Again, moderate to severe and critical, you are going to admit them in hospital. So I'm not going into the hospital management in detail. Again, this is a very interesting slide. This slide just compares the clinical features of COVID-19, influenza, and other respiratory viruses. Please look into the fever. For example, the slide very clearly says less than 43.8% of the COVID patients only, they are likely to develop fever. So as Dr. Kurandasamy sir was also asking about the respiratory distress and other things, similarly, without fever also, the patients can be symptomatic. So don't expect fever to be further investigate. I would say the dictum now is any unusual onset of symptoms, think or rule out a possibility of a COVID-19. And also the season has started where we're going to get winter, rainy seasons. So the influenza, flu-like symptoms will also be there common. So keep that in mind. And one more point we have to keep it in mind is mixer infection. Now there's an interesting guideline from the Government of India. They are talking about dengue because the season for dengue is also on the rise, and also leptospirosis, scrub typhus, and other things. Plus, so keep mixer infection along with COVID also, you have to think it, or patient who has recovered from COVID-19 may also likely to get the infections like dengue and other common infections. Again, apart from many clinical manifestations, please remember dermatological manifestations of COVID also we are seeing in our practice, even though it's not a common. You can just go through that maculopapular exanthematous, vesicular lesions, urticaria, and ischemic lesions because of the vasculopathy. Because of the vasculopathy, they can have dry gangrene and they can have a perino-like skin lesions. So these are the few pictures which we have seen in our practice. So just the unique thing, what I'm trying to say is skin manifestations also we have to look for. Okay, now we'll go to the investigations. As far as investigations are concerned, these are the important investigations we have to do. Next question comes whether we should do for everybody. As I said, if the patient is having just fever or extreme, one more point I want to add, as far as clinical features are concerned, in old people, in geriatric age group, I said fever may not be there, but most important symptom is extreme tiredness and fatigability. Extreme tiredness and fatigability for old people. Of course, for young adults or around 40, 50 years, respiratory symptoms will be more. So you can just do the CBC and look at the NLR. That is neutrophil lymphocyte ratio, which is around 3 point, more than 3.4 is significant. And also it has a outcome, prognosis also we have to watch. Then you do a pulse oximeter, X-ray chest, and you can do a liver functions and renal functions. This is enough as far as, if possible, CRP for the mild patients. But if the patient is having breathlessness or if the saturation goes below 95, definitely you have to monitor all these parameters. They are important for not only diagnosing the course of the illness as well as for prognosis. Again, I have spent some few minutes on the antigen and the PCR and antibody test, because this is a frequently our doctors, they discuss. Sir, what is the use of antigen test? You just look into the graph, the threshold is different. For example, the threshold for RT-PCR is very low. And also you have to understand RT-PCR detects the dead virus also. That is why some of the people who are more than 10 days of illness also continue to show RT-PCR. So please remember, RT-PCR positivity means they are need not be infective. RT-PCR means they are need not be infective. In contrast, if you look into the antigen test, where you need a higher threshold, but now the rapid antigen tests are available outside Tamil Nadu, where if the test is positive, it has a high value. That means patient is likely to be infective, number one. Still, if antigen is negative, still you are suspecting the patient is having a problem, then you can do a RT-PCR. The advantage of the antigen test is it's available at the point of contact. This is something like a pregnancy test, strip test, which we can do. But right now, we are not promoting in our state. This is for your understanding. Again, the interpretation of the test depends on the probability. Just one point, if the probability is high, if the test is positive, then 99% you are likely to have this problem. If the probability is less, still you can be positive, then the probability is 45. If it is negative, it is less than 1%. So please don't treat the paper, but find out the probability of that patient getting or having a COVID-19. Again, these nasopharyngeal and oropharyngeal swabs, of these two, nasopharyngeal is more useful. Again, if you look at the virus, it goes down. After a few days, the infection or the virus goes down to the lower respiratory passage and lungs. That is why if the tests are negative in the upper swabs, you have to go for a bronchoalveolar lavage or a tracheal aspirate. Again, this is very, very important because the technique is very important. If the technique is not correct, probability of getting a negative test is high. Again, these are other two terms. Now it is frequently used, TrueNAT and CPNAT. This also detects something like a RT-PCR. The advantage is individually 1 or 2 samples can be done. Turnover time is around 1 to 1.5 hours, and the cost is also low. Otherwise, if you are going for a mass, at a time I want to do 90 samples like that, then you go for the RT-PCR. If you want to test only few samples, CPNAT and TrueNAT are useful. I already discussed about antigen test. Again, this is, as far as antibody tests are concerned, we have got 3, IgA, IgM and IgG. Still, the usefulness of antibody test right now, it is only for surveillance. It is to know what is the surveillance in the community, how many people are infected. Otherwise, it doesn't have much value. And please remember, this is very, very important. COVID-19 patients can have dengue cross-reactivity. So false negative and false positive can occur for dengue in COVID-19 patients. Let's just keep it in mind. And it is also the antibody response. Sometimes it can be counterproductive. That's what we are seeing in the antibody-dependent enhancement syndromes like your Kawasaki disease that we will discuss later. So the role of antibodies is also a very tricky situations in COVID-19. Again, as far as neutralizing antibodies are concerned, today we are talking about convalescent plasma therapy. So that is useful to know whether the patient has adequate antibodies so that his blood can be given to somebody. Again, we are talking about the word immunity passport. Again, one more key word which I forgot to discuss is the happy hypoxia. That is what very, very important compared to other infections or other respiratory viral infections. Here, even when the patient saturation is around 90 or 80 like that, patient may not develop obvious symptoms. So that is why they are thinking that patients are all right. So and when they slip into a critical stage, they bring the patients to home. So the best way to monitor them, which I already discussed, is the pulse oximeter. So nowadays the CDC recommendation is the thing, keep distancing. That's very, very important. Again, only if the patient has a vulnerable status, you go and test them. You need not test everybody. And you should, the carry-home message, I would say, if somebody is having suspected COVID like fever or cough or sore throat, the first advice as a primary care physician, you should say, get isolated. Please go and be in a separate room. Don't get mixed with others. Testing and other reports or comes later. So best advice is to get isolated. Now we'll go to the other side of radiology. Other side of investigation is your radiological. Again, radiological investigations like X-ray is very, very important. So the characteristic features of the radiological investigations are predominantly it affects the lower lobe bilateral. It affects the peripheral because the ACE receptors are in the subpleural region. That is why you get the peripheral lesions are more common. You get multiple lesions and we get the ground glass appearance plus or minus consolidation. So this is the characteristic radiological X-ray findings. So this is a summary of what I have just now told. It can have a round ball like what you see here. These are a very other presentation round ball. This is a typical ARDS like picture. Again, this is round imode. They call it as round consolidation with peribronchial involvement. So these are the characteristic X-ray features. Again, the CT, I find the popularity of CT scan in Tamil Nadu is very high. Even nowadays, something like a blood sugar, the person himself goes to CT scan place and get a CT done before he sees the doctor. Of course, CT is very, very picking up the finding is much more than X-ray, but I think we have to use that also very judiciously. These are the important findings. Just one thing about the CORADs, because many times when you see a report from the scan center, they call it as a CORAD scores. This is the CORAD scores they are giving up to 6. 6 means PCR is also positive. Possibility of very high 5, high is 4, intermediate 3, 2, 1 like that. Then they are dividing into, our both lungs together, they have got 5 lobes. So they're giving points depending on the percentage of involvement. So the maximum points for in a patient will be around 25. So they are giving the scoring system, maximum is 5 points for each lobe. And depending on the involvement, they classify as severe, moderate, like that. So this is just to tell you about this, assessing the severity of involvement through the CT scan. Now we'll go to the complications. Just I'll take another 5 minutes. We'll try to finish it off. Regarding the complications in the natural history of the COVID, after the patient goes for a respiratory pneumonia like picture, they can land up with sepsis and septic shock, ARDS and refractory hypoxemia. Happy hypoxia I already told. But nowadays, in what we thought as a respiratory syndrome, today it becomes a multi-organ post-inflammatory syndrome. So we are seeing patients with acute coronary syndrome, heart failure, myocarditis, dysarrhythmias, hypertension, and most important is the thromboembolism. So the virus has becoming a vasculopathy. So that is why it has become a prothrombotic state. That is why the role of anticoagulants has come into vogue. Again, diabetes management is going to be very, very important. And some of them, they go for a diabetic ketoacidosis. Apart from that, they can develop gastrointestinal, acute kidney injury, neurological. They can present as a stroke. They can present as some kind of a neuropathies all this Guillain-Barré syndrome, like all this we have seen, and skin we have already discussed. Again, post-discharge, again, one of the important thing which we are following up is for post-pulmonary, post-COVID pulmonary fibrosis, stroke, and now the another interesting phenomenon that comes is the reinfection. So many times we don't know whether it's a reinfection or relapse of the previous infections. So this we have already discussed. Two important words about the COVID-associated hemostatic abnormality. This is, as I said, COVID is a prothrombotic state. Thrombocytopenia is at best moderate. Fibrinogen levels tend to be higher. D-dimer tends to be higher. Prolongation of PT and APTT. And as I said, it's a prothrombotic state. Again, hyperinflammatory syndrome, especially in pediatrics. We are seeing patients in the pediatric group, this Kawasaki disease. These are the important features that because of shortage of time, I'm not going to that. But just remember, coronary artery aneurysm is a very, very characteristic features of this Kawasaki disease. Again, as we discussed about neurological and cardiovascular thing, and especially as well as cardiovascular, I think all of us know regarding the QT prolongation of chloroquine or azithromycin. So please remember to take a ECG if you are putting the patients on these drugs. But remember that primary cardiac involvement is also a possibility. Now we'll go to the last part, is the management. Again, Government of India and Government of Tamil Nadu is very clear about the level of care to be given to the patients. I'm sure all of you know that also. So for primary care, like Corona care centers or patients who are positive, but they do not have place or a facility to get isolated at home, they come to the Corona care centers. Throughout Tamil Nadu, so many centers in the colleges, engineering colleges, malls, everything they have opened. And that's made a very big revolution. I think one of the important things what we have learned about COVID-19 is the participation of the government services, how they can bring a change in the management of an infectious disease. And of course, next is the designated COVID health centers where oxygen can be given and monitoring will be there. And finally, the designated COVID hospitals where the critically ill patients are managed. So I'm just want to show some of these things which really I want to appreciate in government. You know, in government hospital, how the diet used to be given those days. COVID has brought a tremendous change, not only in our hospitals, throughout the state. One of the important things is a good nutritious diet. Just I'll run through the slides which we have been providing in our hospitals. They are not only provided, they are neatly packed also when they are served. We are serving to more than 800 to 900 patients per day. That too around 6 to 8 times. They get around 6 to 8 times per day servings. All nutritious diet. Okay, regarding the final on the treatment, these are the various options are available. So still we don't know the effective antiviral drug for this. Because we are short of time, I'm just telling only 2 or 3 points. The best drug which is available right now, I would say oxygen. Oxygen is going to be the further treatment which is going to improve the prognosis, and various ways of delivering oxygen, all of you know, starting from ordinary nasal prongs to mask and to high flow nasal oxygen. And finally, again, if at all we have to go for invasive, we have to go for an endotracheal tube ventilation. Again, antibiotic steroids. One of the drugs which has shown clearly an improvement in the outcome is the steroids. Again, anticoagulants will help the patients to prevent the thromboembolic and thrombotic states. Monoplasma therapy, again, a lot of controversy is going on. ECMO and lung transplants are we've been tried. We are getting some few encouraging results. So I'm not going into the, all these drugs are putting into use. If you have any questions, I'll take it up. And now we are talking about antifibrotic agents also, like perfidine at the time of discharge. Of course, Ayush is also playing a role on its own merits. And we have to be very careful. This is for the primary care doctors. Please look into why they are using. If you look into why they are using, you can see these catchy words. They are using on compassionate ground. They are using on experimental use or emergency use authorization or off-label use. These are the words they are using for various drugs when they are recommending for some cases. And we are very fond of repurposing of drugs. Repurposing means the drug is meant primarily for one reason, but we are very fond of using it for some other indications also. The classical would be hydroxychloroquine, chloroquine, doxy, ivermectin, lopinavir, and ritonavir. So I will not go all these drugs, you know better. I'm not going to the thing, but this is a very important study of the recovery trial, which clearly showed about the importance of decadron and steroids. Only thing, when you put the patients on steroids, please monitor the glycemic control. This is very, very important. You have to switch over to insulin if need arise. Another problem with starting steroids will be the spondyloitis hyperinfection, for which only the recommendation is you can give 1 dose of ivermectin. Otherwise, there's no consensus or approved or evidence base for ivermectin. Again, tocilizumab has a very good effect, but when you are using it in COVID patients, think of secondary infection. That's a very, very important problem. Again, low molecular weight heparin is definitely doing its role in Cat B and Cat C patients. Again, post-COVID issues, stigma, anxiety, and depression, pulmonary fibrosis. These are the issues we have to keep. In fact, in the months to come, we have to handle more post-COVID problems. So, நம்ம ஹிஸ்டரி கேட்கும்போது டிபி இருக்கா, சுகர் இருக்கா, பிபி இருக்கான்னு கேட்குற மாதிரி உனக்கு கோவிட் வந்துட்டு போச்சாங்கிறது வந்து இட் ஷுட் பி a routine question in our practice. Again, vaccines, there's a lot of trials are going on, including India. So these are the few questions that we have to answer, whether it's going to protect from infection or from disease. How many doses we are going to need? Again, now that they said you need 3 doses over a period of 6 months. Will they be enough to prevent the infections? How long it will take to protect you? And whether so many vaccines can be made, whether the old people also will be benefited by the same thing, cold chain, all these issues we have to keep it in mind. So to conclude, the title of my talk was what is unique? So the unique is it's a modern pandemic. I think we are facing for the first time for most of the doctors. It has taught, it's a great teacher, and infection is being transmitted even before the onset of symptoms. So masking is an important thing. Masking and social distancing are going to be important factors till we find a vaccine or an antiviral drug. Again, the important, one of the unique symptoms we've come across is loss of smell and taste, hypoxia, gentle on children and pregnant women. We call it as an infectious vasculopathy, and it results in hyperinflammatory state involving multiple organs. Inflammatory markers, which we have already discussed, not only help in prognosis and also in treatment selection. And again, I said virus does not kill, it is a host inflammatory response that kills a patient. Mask, distancing, hand washing, home care. I think this is where the primary care physicians, they play a big role. Adequately educate them about the importance of home care, including disinfections and other things. Steroids and heparin can improve the outcome. Again, plasma therapy, it had some encouraging results, but not proven. Again, sudden death, that also we are saying some of the patients who are there in the ward, suddenly they are collapsing. So sudden death is a possibility. So that is why close monitoring is very, very important. There is an unprecedented progress towards the vaccine. And of course, there is much still to be done. So the carry home message, mask is a vaccine, hand wash is a medicine, distancing is a immunity, early detection and effective treatment are the key for our COVID-19. Thank you. Thank you very much.
Thank you.
So if there are any questions, they can put it in the chat box or we can take it.
Dr. Raghunandan sir.
Yes, sir.
Really very great.
Thank you. Thank you.
That the final slide, excellent one, very excellent one that you have shown. That mask is the vaccine, hand wash is the medicine, distance keeping, that is the immunity, early detection and effective treatment are the key to get out of it. And really all the three, panelists, you have done it very well. From the day of Bible, you have been derived the situation of pandemics and viral infections, various viral infections. And like a small feeding the baby, that you have been given all the, details very, very effectively. So a few questions are there. And the things that you have told by the other people, that virus is not going to kill anyway, but the problem made by the viral, that is the thing that we have to identify and then treat. And the family planning done by the infectious diseases that naturally it's existing. There's so many interesting things you have been told. Then false positivity of dengue, that is there. So even every case of positive for corona, they are positive for dengue also. So that is very well been confirmed by you, and then we are now getting a confidence. Sir, somebody has asked me to repeat the procedure to join the course. Says for all the participants. As you are IMA member, you have to join IMA CGP also. That in the IMA TNSP website, you can see what is the procedure for that. In all our TIMA magazine, we are sending information about that. And you can very well see that and become IMA CGP member. And then you have to fill up a form to get into any one of